All righty. I again want to say welcome. My name's Ann Luciano. I'm a nurse practitioner at the University of Michigan. I'll be the moderator for this evening, and I'm pleased to present Dr. Nigel Santos. He is a board-certified cardiologist and a current Jaff Fellow for the Society for Vascular Medicine under the Michael Jaff Fellows Leadership Institute, and he's also a Vascular Medicine Fellow at St. Luke's Medical Center in Quezon City, Philippines. Go ahead, Nigel.
Thank you so much, Anne. So I'm here to talk about the Crest-2 trial, which came out November last year. It's one of the groundbreaking trials because I think it really challenges the dogma of how we manage patients with asymptomatic carotid stenosis. So sorry, can you see my slide? So just a brief backgrounder on how we've been treating symptomatic carotid artery disease in the past. You see here on your left, we have several trials that looked into the benefit of carotid revascularization for patients with moderate to severe stenosis. And what we've seen trial and trial again is that if you have severe stenosis that is symptomatic, especially if it's more than 70% by PSV criteria on ultrasound or by catheter angiography, carotid endarterectomy really is the best way to go in contrast to carotid stenting. But for asymptomatic carotid artery disease, there is still a dilemma across the world on how we treat these patients. Should we revascularize them? There's a diverse practice all over the world. In certain European countries, like for say in Germany or in Denmark, even with patients with severe asymptomatic carotid disease, they do not do any sort of revascularization unless the patient develops a transient ischemic attack. But in the United States, around 60% of patients undergo, 60% of asymptomatic carotid artery disease patients undergo carotid revascularization. And the preference in the guidelines was mainly because of the Crest trial, more for carotid endarterectomy than for stenting. So both in the Society for Vascular Surgery, I think is the American guidelines, and the European Society for Vascular Surgery, they really prefer the carotid endarterectomy. But take note, these guidelines were in 2021 and in 2023, and so they haven't incorporated the Crest-2 yet. So we'll see what the results are. So Crest-2 is two trials that are both observer blinded, and essentially they had a stenting arm and an endarterectomy arm, and they included over 155 centers from 5 countries, over 2,485 patients in total. And I think the main strength of this trial was really screening the stenting operator competence. Specifically, for you to get involved in the trial, you had to have the interventionist had to have a procedural stroke rate of less than 3%. The surgeons had to have a procedural stroke rate of less than 6%. And so they included anyone from interventional cardiologists, which was the majority of the doctors included, neurosurgeons, neuroradiologists, vascular surgeons, and even interventional neurologists. All FDA-approved stents and EPD systems were allowed at the operator's discretion, and closed cell stents were encouraged. So the major inclusion criteria was the patient should not have had a history of stroke or TAA within the past 6 months. This is the classic definition of asymptomatic carotid disease, even in the previous trials. And patients had to have severe stenosis of more than or equal to 70% by either catheter angiography or duplex ultrasonography. Exclusion criteria included previous disabling strokes, if you had unstable angina and AFib prompting anticoagulation. Now, the key exclusion criteria in the stenting trial was that if the lesions were long, if they were circumferential with calcifications, if they were severely tortuous lesions, if you had problems with the aortic arch or even the proximal common carotid artery, which we think is because of the difficulty of trying to maneuver all the equipment and the stents through the arch and the proximal common carotid artery, because again, the access here is transfemoral and not transcarotid. And patient selection was left to operator discretion. For the key medical management arm, it was implemented by individual sites. There was central oversight, reminders, and assistance, and lifestyle management coach was assigned to each patient. Please see here the target goals and for the risk factors in the Crest-2 trial. The major primary risk factors they controlled was the LDL of less than 70 and a systolic blood pressure of less than 140. But later on in the trial, as new guidelines came out, they tried to achieve a much slower systolic blood pressure of less than 130. And these are the other secondary risk factors included. So in terms of randomization, it was successful in that there was no significant differences in the baseline characteristics on each of the two trial arms and the arms of each trial in the Crest-2. And this goes for the comorbidities and even the level of stenosis, as well as the modified Rankin scale score for, strokes in the past. Distribution of degree of stenosis, there was a broad distribution of ultrasound PSVs consistent with a more than or equal to 70% stenosis, and about a third of patients had velocities consistent with more than or equal to 80% stenosis. So they had a good inclusion of asymptomatic severe carotid stenosis that was representative of the population we were trying to test. So the primary outcome was a 4-year composite of any stroke, death, and ipsilateral ischemic stroke. The independent stroke adjudication committee was blinded, but the patients as well as the caregivers were not. And these are the other secondary outcomes. So let's look at the results. So stroke and death rates out to 4 years was 6% in patients assigned to the medical management group, while stroke and death rates was 2.8% when stenting was added. The absolute risk difference of 3.2% was in favor of stenting, and this was deemed to be statistically significant with a P of 0.016. For the endarterectomy trial, a stroke and death out to 4 years was 5.3% in the medical therapy group and 3.7% in the endarterectomy group, plus Beth medical therapy. And the absolute risk difference of 1.6% was still in favor of carotid endarterectomy, but did not prove to be statistically significant. So looking at the patterns of differences in the CAS and the CEA trials, these were actually mirrored in the 44-day peri-procedural period. However, in the post-procedural period, which was defined as 45 days out to 4 years, both stenting and endarterectomy performed better in terms of preventing stroke and death compared to their respective medical management group. So these are the outcomes of revascularization when we put all the Kaplan-Meier curves on top of each other. And as you can see, stenting really had the lowest level of event rates out to 4 years. This was followed closely by endarterectomy, which was again not statistically significant, and medical therapy on each of the arms. Now, I think it's important to point out that it is expected in these trials that the medical therapy would evolve, but we had to commend the trialists because I think this was one of the trials in history to have documented one of the lowest stroke rates in terms of best medical therapy. So actually, best medical therapy is highly encouraged now, and I think it will have a much stronger recommendation in the guidelines, especially for asymptomatic carotid stenosis. So as you can see, the stroke and death rates for the stenting group had an annual stroke and death rate of 1.3%, and for the endarterectomy group is 1.5%. So that is much lower than what we would expect for patients if you had asymptomatic carotid disease more than or equal to 70%. Your annual risk of death and stroke, based on retrospective studies, is around 3 to 5% per year. So this has reduced it by more than half. This was the peri-procedural component I talked about earlier. So what are the outcomes for the medical management group? Medical therapy was successful. Guideline-driven targets for each of the 7 primary and secondary vascular risk factors were all met. 40% of the patients entered the study at target control, and about 70 to 80% of the patients were at target control by the end of the study. However, I think one of the major critiques for this trial was that the primary target set out at the start of the trial did not reflect the current guideline-directed medical therapy, or what we deem as the optimal medical therapy now in 2026. Because remember, this trial started out in 2015, more than 10 years in the making. So definitely the goalpost for best medical therapy had evolved since then. And as you can see, this was in the European Society of Cardiology from last year. The recommendation of less than 55 milligrams for deciliter for LDL is much lower than the Crest-2 goal of less than 70. And even in the Vesalius trial, which came out more recently, it showed that if you had a much lower LDL of less than 40 milligrams per deciliter, this was the more appropriate target LDL for patients that are very high risk or had polyvascular disease. So these are essentially the proportion of patients in target range. As you can see, all of them were below 80%, around the 70 to 80% range, both for target cholesterol and systolic blood pressure. But in terms of the A1C, the non-HDL, and the BMI, this was much less than 80%, which I think warranted the critique from all the other trialists that were pro best medical therapy. So what is current optimal medical therapy? So again, trial started in 2015, and these were the trials that came out around in 2016. You have lowering of the blood pressure target, lipid lowering much lower in 2016, and then aspirin or clopidogrel for MACE reduction. And this was also followed by some of the trials. We had COMPASS trial, which also incorporated aspirin plus low dose rivaroxaban, which also included a reduction in stroke rates. So these are the trials definitely warrant mentioning. And of course, we have to take it with a grain of salt on how we're going to apply the results of this trial. Now, the optimal medical therapy we define now does not necessarily reflect what has been defined in the trial. So the caveats and limitations: patients and the treating MDs were not blinded. Evolving medical therapy practices occurred during the trials and could lower stroke rates and negate any additional benefit of revascularization. Of course, transcarotid artery revascularization, or TCAR, I think is more common in the States, also in the Philippines, because we really mirror the practice in America. This came into frequent use after approximately half of patients undergone randomization. And so we could not deduce what we cannot generalize the results of this trial to transcarotid artery revascularization. And revascularization was performed only by well-trained and certified high-volume operators. Remember, for interventionists to be included in the trial, they had to have a stroke rate of less than 3%, and for surgeons, less than 6%. So we'd only be able to generalize the results of this trial if you were in the vicinity of a center that could afford that level of care. What would be the role of BMT? So extensive efforts to measure risk factors and medications in Crest-2 trial were commendable. The targets evolved during the trial, as expected in any long-term clinical trial, and missing elements of course of treatment like rivaroxaban, your GLP-1s, your PCSK9s were not incorporated in the trial. PCSK9, I think, only came about later on in the trial. They gave it for free for some of the patients, but they did not specifically include that as a major proportion of patients included, and whether or not the patients reached the less than 55 mg per DL goalpost was not mentioned in the trial. And so there's a remaining question of residual risk in the truly optimally managed patient. And the strategy is we should really maximize optimal medical therapy in all patients, regardless of interventional strategy. So for our conclusions, the Crest-2 trial demonstrated that transfemoral carotid stenting performed by competent operators in appropriate patients, when offered in addition to medical therapy, reduces the risk of stroke and death out to 4 years, from 6% for medical therapy to 2.8%. So our number needed to treat was 31. So 31 people with high-grade asymptomatic carotid stenosis needed to be treated to prevent a primary event at 4 years. And the results of this rigorous trial is translatable to general clinical practice, where best medical therapy is less optimal, and providing stenting operators practice competence stenting with appropriate quality control and oversight, as I mentioned previously. So that's basically it.
Great. Excuse me. Thank you so much. If anybody has any questions, you can use the chat or you can use the question and answer box. So you practice in the Philippines. What healthcare barriers do you see for your patients? Are they similar to what we see here in the United States?
Yeah, definitely. So I think well, the burden of disease is similar. Atherosclerosis is still one of the major issues that we deal with on a national level. But in terms of our healthcare system is primarily out-of-pocket expenses compared to what I saw when I was in the States, where I think insurance companies are the ones that cover most of your medical costs. So that definitely is one of the major barriers, especially with these kinds of diseases. Patients have to pay for both best medical therapy. Like, for example, the PCSK9 inhibitors are expensive drugs, the GLP-1s are expensive drugs. So those have to be shouldered by the patient, in addition to, like, say, procedures like this, where only a handful of centers can deliver this type of care.
Um, and then do you have a pretty robust follow-up um, process? Follow-up phone calls or lifestyle coaching? Does your nursing team do that for you?
Yeah, okay. So I think it really depends on the institution. For tertiary care centers, the follow-up process is robust. So there's early incorporation of cardiac rehabilitation services. So the nursing care personnel there, the doctors are the ones who follow up the patients closely. Follow-up phone calls really aren't popular in the Philippines. People would really rather go for face-to-face consults. But for tertiary hospitals under, government control, like public hospitals, as I would say, because of the volume of patients, I think the follow-up is not that robust and is something that we need to improve on.
Um, hmm, any different strategies to support adherence to the Crest-2 recommended guidelines?
Yeah, thank you for that question, Anne. So I think what Crest-2 translates to in practice is not that endarterectomy is, like, a failed intervention. It just challenges the dogma that all patients with asymptomatic carotid disease of more than or equals 70%, now we have the option to really go for best medical therapy first, because as you can see, the level or the percentage of a stroke and death at 4 years is just 6%, 5 to 6% for both the best medical therapy arm. And that's one of the lowest we've seen because our medicines have evolved and have changed. So I think, especially for the Philippines, where revascularization is not really the first option to go to because of out of pocket expense type of medical system, really best medical therapy is the way to go, unless there are certain risk factors that we know increases the risk of stroke. The character of the plaque, if they have intraplaque hemorrhage, if they have high echoleucent plaques on their carotid ultrasound, of course, if they have low brain reserve in the perfusion imaging, and if you have, say, if your patient was to undergo a bypass procedure where the risk of stroke is just too great and we have to reduce that level of stroke. So I think only a handful of patients should really undergo carotid revascularization. So maybe I think that's what we should get from the Crest-2 trial. It should not be misinterpreted that all patients now should undergo stenting. Is that all patients now should get the best medical therapy and select the patients that would benefit for stenting and revascularization.
Yeah, I agree. I'm hearing they're working on the new carotid guidelines right now, and I'm hearing that there's a large percentage of the people who are doing the writing that kind of favor that response of everybody gets good medical therapy and only certain patients should get revascularization for the asymptomatic patients. Um, and then you're probably going to clash with all the interventionalists who see it differently. So hopefully the guidelines come out soon, but I suspect they're going to take quite a while this is figured out.
Yeah, I agree. I think in terms of the level of recommendation, before there was really a strong recommendation for surgery as like first line for more than 70%. But now I think the guidelines will soften that out and, really encourage best medical therapy, which I think is better for the patient, lower costs, more cost efficient.
Yeah, yeah. So I'm from the University of Michigan. We're a huge tertiary care center. We have like 1,200 beds now. And so we have a vascular medicine department. And so I just have to walk across the hall and grab my vascular medicine specialist and we can talk about patients. Do you have any recommendations for those sites that don't have a vascular medicine team?
Yeah, so that's a difficult question. And I
Yeah.
think it's also a current issue we face in most of the areas in the Philippines. I think now with the technology of, being able to reach out to people from half across the world, like we're doing right now, I think using the technology that we have to reach out to the mentors. Of course, I think Society of Vascular Nursing is very strong in partnership with Society of Vascular Medicine. So I think for people who do not have that sort of community, they can reach out to the societies for help. It's a very friendly field, and I think anyone's just welcome to get questions and get asked about how you go about and treat patients, or if you want to do observerships or shadow a specific physician. I think that's not a big issue.
Yeah, thank you. And I'm putting in, excuse me, the chat, the link for the vascular surgery clinical practice guidelines for cardiovascular disease. Um, do you have any recommendations for sites so that they can meet best medical practice prior to revascularization?
Yeah, so I think really you'd have to strengthen the, system support for provision of the best medical therapy that we know of. We know that GLP-1s can, reduce cardiovascular events, stroke, like even simpler medications like rivaroxaban, PCSK9 inhibitors. So I think really providing a much lower cost for this medications or even coverage from the government is really the first step. Because, as I've said in the trial, the results of the revascularization are not of their own. It's revascularization plus best medical therapy. So, majority of patients with peripheral artery disease, carotid artery disease, and coronary artery disease really benefit most from optimal medical therapy more. So I think setting out algorithms, setting out, local practice guidelines for frequent follow-up of patients. And also I think having, passionate members of the team, especially encouraging the work of our nurse practitioners here who can also follow up these patients and treat these patients. I think that will be the first step, getting more people to, identify patients at risk and then stratify them and give them the appropriate medication is really the first step in trying to optimize treatment.
Yeah, so really, we were kind of talking about timing of procedures. So really, like today, I saw a patient. I was doing an H&P for carotid stenting, and his LDL is 70. So
Mhm.
really, we should optimize his LDL before we schedule a procedure to
Yeah.
get the best outcomes after the procedure.
Yeah, I agree. So I think in the trial they included patients who had like just for only 40% of the initial control group uh, was in target by the time they were enrolled in the trial. And, I think even if that's what they did in the trial, I think that's not what we should be doing in clinical practice. We should optimize best medical therapy first.
Yeah. Let's see. What assessment tools or clinical findings should the care team prioritize to stratify stroke risk in asymptomatic patients?
Oh, okay. So, I think I have a slide for that. This was not in the Society for Vascular Surgery guidelines, but I think it's really helpful. This was in the European Society for Vascular Surgery guidelines, and I think they did a more in-depth review of which type of clinical and or imaging findings were associated with increased risk for stroke in the next 5 to 10 years. So I think if you have I think it's written there, if you have a silent ipsilateral infarction, if you had stenosis progression, specifically more than 20% or even any progression, if you have, plaque hemorrhage, if you have impaired cerebrovascular reserve, plaque lucency. So I think these are the major risk factors that have been proven to increase your risk for stroke and death in the next few years. So in terms of trying to stratify patients, if your patient does not have any of these, I would go for just best medical therapy alone. But if the patients would have any of these, then I would discuss with the patient the risks of, undergoing endarterectomy and or stenting. And of course, we have to take into account the exclusion criteria I mentioned earlier about, if the lesions are long, if there's circumferential calcification, we can, those patients are also high risk for having a stroke. And I think that's the reason why they were put on in the endarterectomy group more than the stenting group.
Right. How can vascular nurses identify patients with asymptomatic carotid stenosis who may be candidates for medical management versus referring for revascularization? I guess that's kind of
Yes.
a question.
Yeah. So I
Any
think
medical
it's
management.
yeah, but that's a clinically, I think the interesting thing about carotid disease is really the index of suspicion because, in the clinics, I think NPs also do physical examination, and the NPs I've met at least in Ohio, they were, and in California, they were really good in their physical exam. So, screening patients for carotid bruits, I think is an important bedside step to do. If you have any previous history, just asking the right questions. If they've had, monocular blindness, amaurosis fugae, if they've had a transient ischemic attack. But again, even if the sensitivity of the physical exam for trying to identify patients with carotid disease is not that high, it's like 50 to 60%. So if you have an index of suspicion, say they have polyvascular disease, say they've had coronary artery disease plus peripheral artery disease, then maybe these patients are the ones who should get screened so that the NPs and even the AMDs can pick up these patients and then give, intensify the medical therapy.
Um, in light of the Crest-2 findings, how should NPs modify counseling for patients with asymptomatic carotid stenosis regarding their
Yeah,
stroke risk and management?
yeah, great question. So I think the guidelines will really shift towards a best medical therapy approach first. So I think the NPs there, if they've had severe stenosis, the first thing is, offering the patient revascularization. So I think that would really change in the years to come to offer all the armamentarium first of best medical therapy and then proceed with revascularization if they have more severe findings. Of course, close monitoring, ultrasound imaging of the plaque, trying to do a perfusion scan if you're not sure if they've had infarction in the past. And that's when you rely on tissue-based infarction diagnosis on the WHO guidelines.
Awesome. Thank you. I don't have any more questions. Anybody else in the chat or in the question and answer section? All right, beautiful. Well, we'll give you guys some time back this evening. Thank you all for attending. And thank you so much, Dr. Santos, for explaining the Crest-2 trial for us. Have a good
Thank
evening,
you.
everyone.
Thank you for having me. Thank you so much.